Yeah, hello. It's my great honors on behalf of Professor Shaoliang Chen to perform this second case. It's a TAVI case for severe aortic stenosis. Can you hear me? So let me introduce my team. On my right side, Dr. Kong, Dr. Zhu, and Dr. Ye. And also Dr. Zhang Juan is an echocardiographer to guide the TAVI procedure. So next slide. Let me show you the baseline slide. So actually, it's an elderly patient, 73-year-old gentleman, presented with chest pain for 10 years and also warfarin for 30 days. This patient has a history of COPD more than 10 years and also suffer from CKD. So after admitted, lab examination show elevated BNP, and echo show it's a typical severe aortic stenosis with a tricuspid valve of aortic valve. After calculating the STS score, actually it's a high-risk patient. S score is more than 10. So, pardon, can you show the slides? So let me show you my baseline patient information slides.
I think you can go through the introduction.
Okay.
不对呀，刚才我们都在通话的呀。Hello, can you hear me? Yes.
Okay, so let me introduce the case.
俊杰，等一下。
OK，
我现在好像没连上。
断线了，对对对。
Hello.
Okay, thank you. I'm Dr. Junjie Zhang. My moderator is my chief, Professor Shaoliang Chen. On my right side is my assistant operator, Dr. Kong Xiangquan and Dr. Zhu Jianchen. And today, the echocardiographer, Dr. Zhang Juan, will perform TEE to guidance TAVI procedure. Next. So let me introduce the patient's medical history. This was a 73-year-old gentleman presented with a chest pain with shortness of breath for 10 years and worsened for 2 months. Comorbidity including essential hypertension, severe COPD, and also CKD with a 3-stage. After admitted, laboratory examination show elevated BNP and also EGFR less than 60. ECG show complete right bundle branch block. After risk stratification, ST score was 10%, which means it's a high-risk patient for surgery procedure. Next. So this is a baseline TTE echocardiography for this patient. Actually, you can see from the 4-chamber view and the 3-chamber view, it's a typical severe aortic stenosis with the increased velocity of the aortic valve flow. Next. For the velocity of maximum of the aortic valve is 4.2 millimeter per second. Mean gradient was 42 millimeter mercury, and the aortic valve only 0.89. In terms of the LVEF, it's a normal 63. And also you can notice the enlarged left ventricular and the enlarged left atrium. And also the PASP is retro elevated, 44 millimeter mercury. So according to the echocardiograph finding, the severe aortic stenosis or diagnosis, and also with a moderate aortic regurgitation, LA dilated and preserved LV systolic function with mitral valve regurgitation, mild to moderate, and with mild pulmonary hypertension. Next slides. Of course, before we make a decision how to select the valve size, we should perform a CT analysis. Actually, this is a baseline CT. It's a typical tricuspid aortic valve. You can see the total calcium volumes was more than 400, which means it's a moderate calcification. And also the aneurysm diameter was 27. And also you can see in terms of LVOT diameter is 28. Next. In terms of coronary obstruction risk, we can see the left coronary artery high is 15, and also RCA high is more than 18, and also the enlarged Vasava, so which means it's a quite low risk of coronary obstruction, and also STG mean diameter is 31 millimeter. Next. In terms of the peripheral artery, you can see the right femoral and the iliac artery diameter is 7.7 millimeter. It's large enough. So this is the result of a CT analysis. Next. So according to the clinical information, echo, and the CT analysis, decision was made to perform TAVI procedure for this typical high-risk aortic stenosis patient. We will use general anesthesia with the T and the angio guidance, and from the right femoral approach. According to the CT analysis, the annular diameter was 27. So decision was made to select 29 Tonus elite valve. It's a self-expanded valve, domestic Chinese valve. Thank you. That's our case introduction and the decision making according to the CT analysis. Prof. Yeah. Yeah, it's very important key point for the TAVI procedure, considering it's a CKD3 stage. So before the TAVI procedure, actually we give the hydration for this patient to prevent the CIN. And during the procedure, actually that's why I will use general anesthesia. We will use TE guidance, intention to reduce the conscious fluid consumed, and in order to reduce the risk of CIN. So for hydration, usually how long? Yeah, it's a very good questions. According to the previously coronary intervention area, routinely 1 cc per kilometer per minute maintained before the procedure at least 6 hours. But nowadays, according to the studies, this is we have invasive left ventricular diastolic and pressure monitor. So actually, you can see the left ventricular diastolic and the pressure only 9 during procedure. So at this time for this patient, we will increase the hydration with a speed of 3 millimeter per minute per kilometer. Yeah. Yeah, actually, before the procedure, we perform the coronary angiogram. Yeah, sure. Go ahead. So you see, this is a right coronary angiogram. Actually, there is a minor disease at the proximal to middle RCA. Totally normal. Next. In terms of left coronary angiogram, it's also nearly normal. Maybe there is a minor disease at the proximal circumflex.
So very good coronary artery. So I think this is very important. So if there is a single vessel or multi-vessel disease in coronary artery, would you change your strategy? I mean, before or after TAVI procedure, you will do PCI or even CABG for the patient?
Yeah, that's a very, very difficult question to answer because so far there is no randomized or high-level evidence to compare in terms of AS accompanied with multivessel disease, either cabbage or pars severe aortic valve stenosis versus TAVI pars PCI. But as you mentioned, this case, if the patient has coronary artery disease, consider it's a high risk for surgery. So for me, if the disease is functional significant, so personally, I will use a functional test to evaluate, like FFR, or nowadays we have angio-based QFR to evaluate. If it's non-significant, I will only treat it with AS with a TAVI procedure. If it's significant, considering we use a high self-expanded valve, so for this case, if the procedure PCI procedure is simple, I will treat it at one stage with a minimal contrast consumed with intracoronary imaging guidance.
Good. So now I think it's time to dive into the TAVI procedure. So please introduce step by step about your procedure in details.
Okay. So actually, just as I mentioned, we puncture from the right femoral artery and with a two-plug suture device. So avoid the peripheral artery complication. And also the left femoral artery, we use a pigtail at the aortic root to guidance the valve implantation. So actually, my colleague had used a stiff wire with a straight wire across the valve and put a pigtail at the left ventricular. So next step, I think I will use a round crest wire, put this wire into the left ventricular as a guide wire for the device.
Yeah, this I think a standard steps. I mean, according to the SOP of TAVI. So once you successfully cross the aortic valve, so next step, I think you need to exchange the wire from the pigtail catheter and try to do the pre-dilation, right?
Yes.
According to the measurement by echo, the annulus diameter is 27. Aortic root diameter is 28, right?
Yeah.
So do you plan to select 20 valve in 29 millimeter in diameter?
Yeah, so the valve size, according to the CT analysis, the oversize ratio 1.1. So decision to make select 29 valve for this case. So Chief, if possible, can Dr. Zhang Jue introduce the TE result of this patient?
Yeah, I think Zhang Jue can introduce the echocardiography finding and simultaneously you can easily change the wire to save time.
Okay, Zhang Jue.
Thank you, Prof. The patient actually, this view is a transesophageal view, and the short axis of the aortic valve, we can see this is a bicuspid. Although there are three sinus, but the left coronary leaflets and non-coronary leaflets are fusion with obviously calcificated raphe. So this is a type 1 bicuspid aortic valves, and the 3D TEE alive can prove this and can see vividly. And this view is the transesophageal long axis view. We can see the left coronary leaflets and the no coronary leaflets are restrictive, and the movement is the movement of the right coronary leaflets is reduced, and we can see the turbulence through the valves, and there is also a moderate to severe aortic regurgitation. And by echo, we use the semi-automatic program to measure the annulus of the aortic valve. So the aortic valve perimetry of the annulus is about 81 millimeters, and concordance with the CT results. And we move to the airway function. Actually, the airway function is normal, but the airway wall is quite thickness, and the airway wall volume is not very big. Maybe due to the severe aortic
Yes,
stenosis.
you can simultaneously continue the procedure.
Okay.
Don't need to wait. Zhang Juan, if you have
Okay.
further information to tell us, go ahead.
High
Okay.
speed pacing.
Actually, there is
180.
also mild to moderate MR, but I think the MR is functional. Maybe due to the diminished airway function, and if we resolve the problem of the aortic valve, I think the functional MR may be improved. So
等一会儿啊，
that's
不要
all.
噪音。
That's all
好，错
for
吧。
this patient. Thank you, Prof.
Okay, very clear introduction about the echographic finding. So, Junjie, now I say you have finished the predilation. So tell us usually how much is the inflation duration?
Actually, it's aortic stenosis patient. During balloon inflation, the total output is 0. So for me, at most 5 seconds. Yeah. Inflation time in term.
So a very quick deflation immediately after the inflation, right?
Yes.
So you have used 23 millimeter in diameter of the balloon. So another point is that how do you define the balloon size?
So actually, I think for TAVI predilation, I think we only measure the short distance of the annulus. So should not, in terms of the balloon size, diameter should less than the short distance of the annulus. So according to the CT analysis, the annular diameter, mean diameter is 27. The longer distance is 32. The short distance is 24. So that's why I selected 23 balloon.
So usually balloon diameter greater than 20 millimeter, right?
Yeah.
Good. So now you have finished the predilation, and the pacing of hemodynamic is stable. No any change of EKG. Everything is fine. So what's your next step?
Yeah, next step, I think just I mentioned the patient hemodynamic is stable after balloon dilation. So consider it's a CKD patient. I will not to do the contrast injection in terms of saving contrast volumes. So please, Zhang Juan, introduce the echo finding after balloon dilation.
So this on-site echo.
Yeah.
So I think the movement of the leaflet is improved, Prof, and the relaxation is severe. It's more severe than before. So I think the dilation is effective. Oh, yeah.
So basically, baseline regurgitation is around mild to moderate, right?
Yes, Prof.
So
Maybe mild to moderate, and now it's moderate to severe.
Yeah, from the Doppler flow, so regurgitation is very severe.
Okay.
But the patient now hemodynamic is fine.
Yes.
So Junjie, now I think you can succeed in the next step.
Yes. Okay. So next step is as we decided, we select 29 Bonus Elite self-expand valve.
From which company?
苏州就是 domestic 苏州佩嘉 company.
So far, how many domestic companies are manufacturing aortic valves?
So far there is 4 domestic TAVI valve is available, mechanism available in China, including Shanghai Microport, and also the Hangzhou Venus, and also Suzhou Peijia, and also there is another Suzhou G valve. It's from the Apex.
So what the differences between these different domestic companies?
Yeah, actually, all these domestic valve, except the J valve, all 3 like Microport, venous Michael Porter Vita Flow and the venous A valve, and also this tonus valve is a self-expanded valve. Actually, it's different to the balloon expanded valve. It's a superannular valve.
Okay.
And also, this valve is can be retrieved. It's a second generation valve.
So it's a second generation retrievable device.
Yes. Hold on. Yeah. So you see now advanced valve.
So what's the length of the valve?
For this valve, 25 the length centimeter. So let's go to the IO caudal view. It's an overlap view which will be used to deploy the valve. Please advance the wire. And I will advance the wire to make the valve more coaxial. Okay, good. Please hold the wire. Then deploy the valve. Okay. Copy more code. Okay, it's good. Let's take a picture here. 10 cc.
So usually how long of protrusion into the alveoli?
Yeah, that's a very important questions because these patients, the baseline ECG is complete right bundle branch block, which means that it's a high risk of pacemaker implantation after TAVI procedure.
CLBBB or CRBBB?
Now I think, yeah, now it's
CRBBB.
CRBBB, yeah, CRBBB. So for this case, I will implant it with a high position, avoid high degree AV block after TAVI procedure. So my intention position will maybe with 0 lines. Avoid protruding too much because according to the CT analysis, the vascular member length is only 4 millimeter, which means I should implant at most 4 millimeter. Otherwise, there will be high degree AV block after procedure.
Following 0 line, I think it's a very good strategy to avoid the right bundle block.
Yeah.
But no more effect on the prevention of left bundle branch.
Yes.
So in general, I think the patient will be a very high potential of pacemaker implantation.
Yes.
About TAVI, it's easy.
Okay. So let's take a picture. 10 cc. Okay, ready? Okay.
Almost 0 line.
Yes.
Almost
Okay.
0 line. So following the 0 line, what's your concern?
Actually, during the valve deployed, there will be dying into the RV. So at this time, I think my assistant will advance the stiff wire, and also I will hold all the system, avoid too much. And also during the procedure, I will temper pacing with 120 to 40 beats per minute, where increase stable condition during the procedure.
I think another concern will be the jumping back of the whole system into the aorta.
Yeah.
Because this is a online, a zero line.
Yeah.
So if dive into the LVT too much, it will be easily to jump into the LV.
Yes.
So in terms of the prevention of jumping into either aorta or LV, so what's your technique?
I think it's a very, very important technical question. So I think collaboration with my colleague during the procedure is very important. So for TAVI, I think is a hard team performance. So also the online TE guidance where precisely with multiple modality of imaging guidance. And also during the procedure, I will with a pacemaker temporary pacing with a high speed. Now the BP is lower, maybe 270. And this time during procedure, I will continuously, precisely monitor the the valve position. If the valve is diving, maybe we can advance the wire. If the valve is jumping, maybe I will advance the whole system at the same time. Simultaneously, the assistant operator will hold the wire.
So next concern will be that I think for any intervention procedure, even you are working in a whole heart team. So while the aortic valve jump back into the aorta, so what will you do?
Oh, so that's a very important question. That's why nowadays we use the second generation valve. We can retrieve it and deploy again. So far, we have at least 3 times retrieved. So compared to the first generation non-retrieved valve, nowadays we have a second generation. The procedure is safer compared to previously.
But on the other hand, once the valve jump into the LV, so I think there will be no way to get the device from LV by intervention procedure, right?
Yes, if after the totally deployed, it's jumping into the LV, it's a disaster. So, but for this case, I think the risk may be low because the aortic valve leaflet is also a severe stenosis, which will limit the valve jumping up during the procedure.
Because you are following zero line, do you
Yeah.
have any concern about the occlusion of the coronary artery by the valve?
Yeah, that's another very important point of the TAVI procedure. That's why I think the most important is to prevent coronary obstruction during the PARI procedure. According to the baseline CT analysis, this patient was associated with enlarged SOV, and the coronary high is more than 50 millimeter, which means it's a low risk of the coronary conclusion during TAVI procedure.
Okay. So right now, what are you waiting for?
Okay, I'm waiting your guideline. So now, if you permit, I will perform the procedure. Please deploy it gradually.
Do you need one more test?
Yeah, one more test, please. Small test. Okay, good.
Oh, still is zero online.
Yeah.
Very minimal protrusion.
Yeah. Pacing, please. Pacing.
Pacing on.
114. Yeah, good. Hold the wire. Advance the wire. Yeah. Okay. Pacing.
Very gently, very slowly remove the lung sheath.
Yeah. Dr. Zhang Juan, what's the position of the valve?
So I think the position of the valve is good.
Okay, stop pacing.
Until to the release of the whole valve system. So you still have the chance to retrieve the system.
Now it's about 4 to 5 millimeter below the annulus. Yeah.
Let's take a picture here. The BP is still low. We'll wait a little time for the cardiac recovery. From the cine, from the angio, you can see, I think the position is good.
Good.
I think it's good.
So right now, almost 1 to 2 millimeter protrusion.
Yes. Okay.
This is good. Because this whole system is very rigid. So once the lung lease was pulled back, so do you have any impulse or moving forward of the valve into the LV?
Yeah, at this time you can see I hold the wire and make advance the whole system, make the valve more coaxial, the aortic root.
Very stable.
Yeah. Zhang Juan, so at this time I will double check from the TE. What's the implantation? Is that too high?
Yes, it looks higher than before. Yeah.
You mean the valve?
You mean the regurgitation?
The regurgitation is mild. I think it is because due to the have not totally released the program.
Right. Now regurgitation is decreased much more from the test.
So now you can see I advance the whole system and made the valve to more close to the big curve aorta, made it coaxial. At this time you can see a valve a little diving into.
Right. So I think after full release of the valve, I think everything will be much more better.
Yeah. So Zhang Juan, how about the position at this time? Is the valve all or below the annulus?
Yes.
Yes.
But I think it's zero position. So,
Zero is
so be
what I.
carefully.
Okay.
Not jump into the aorta. Yeah.
Okay.
Cannot be high, more higher.
Okay. Let's take one more picture. 10 cc.
Good. Corner artery looks much better.
Yeah.
No obstruction, no pinch.
Yeah. Okay. I think the position is good. So I decided to deploy the valve.
I agree.
Chief. So still gently pacing 140.
Passing on.
释放。怎么样？张娟位置怎么样？
好的。It's okay.
Now I think the pressure is still a little bit high.
Yeah, 116.
Okay, good.
Good.
Yes. No change.
Okay.
No change means no
position
worsening of regurgitation.
Okay. Now I think we totally release the valve and the position is stable. Stop pacing. And storage.
Usually, Junjie, do you have any experience? I mean, from passing out to the hemodynamic recovery. Usually does the patient need how long time of the recovery?
I think because we have a BP monitor, I think usually at least 30 seconds.
30 seconds.
Yeah.
So I think there will be another very interesting researching point. I mean, the recovery duration from pacing off to the hemodynamic wonderful recovery could predict the possibility of pacemaker implantation and clinical outcomes.
Yes, I think.
So far, I think almost 45 seconds.
Yeah.
So the recovery of dynamic is very slow.
Yes.
But during the pre-dilation using 23 millimeter balloon, recovery is very fast.
Yes. So Zhang Juan, can you introduce the echo finding after the valve deployed? How about velocity? How about the PVR?
The prosthetic valve is the location is stable and not change. But there is mild PVR. This means pulmonary valve leak in the posterior of the valves. I think it is maybe due to the roughing, because it is a bicuspid valve and there is a calcificated roughing. Maybe the roughing blocks the expand of the valve. So maybe the post dilation can be useful for this patient.
Okay.
So this is a non-bicuspid aortic valve disease. So Junjie, usually how many percentage of post dilation required?
So actually, depending on the baseline anatomic, especially for a BAV case and with the severe calcification roughing, we routinely do the post dilation. But for tricuspid and also less calcium, I will only use a valve deployment. So the
Two minutes.
yes. So now I will do a aortic root angiogram.
Zhang, do you have any further finding from echo?
Actually, the functional valve, the function of the valve is good, and only mild regurgitation, and the maximal velocity and narrowing.
maximum velocity is what? Is measured.
I'm measuring, Prof. It is now. It is about 2.0, yes, meter per second, Prof. Yeah, it is in the normal range.
And now, how many pressure gradient?
I think there is no pressure gradient for this case. Less than 5 in terms of systolic pressure.
Around 5 to 6
Yeah.
millimeter mercury. So baseline pulmonary arterial pressure was 43 or 44, right?
Yes, from the echocardiography. But before the just prior to the procedure today, we performed the right heart catheterization, and the result shows pulmonary mean pulmonary artery pressure only 17, and the P
17.
yeah 17.
Cool.
And also PCWP only 8, and also PVR only 1.67.
So I think this finding is very consistent with the baseline cardiac echo measurement.
Yeah.
But very good. LVEF patient symptom was very stable.
Okay.
So now the gradient pressure.
The mean pressure gradient is about 5.
Okay.
Similar to the.
And the velocity is about 1.8 meter per second, Prof. It's quite good.
Very similar to the invasive measurement.
Yeah.
Not only 2 or 3 minimum mercury. So Junior, what's your final step?
Final step, I will do the aortic root angiogram. So ready? 15,
Sure,
15.
Very mild regurgitation.
Yeah, very mild regurgitation.
Junior, could you find the PVR? I mean, per valve regurgitation.
Yeah, there is mild PVR, yeah, regurgitation.
On the upper reach, right?
Yeah, so maybe we can go to another view, LAO view, to separate the right coronary and the left main.
Coronary artery is good.
Yeah.
So I think next time, because you are very skillful, so TAVI procedure only needs, say, almost 30 minutes. So next time we can leave almost one hour and almost 20 minutes for coronary for complex PCI.
Yeah, definitely. Yeah, TAVI procedure after with excellent design before the procedure actually only maybe less than half an hour. But for PCI, especially for today's case, where maybe more time are needed.
Okay.
So let's take one more picture.
Aerocranial view. Even much better than AV caudal.
Yeah.
I could not see how much is the regurgitation.
Mild regurgitation,
yes.
yeah.
So I think we don't need to post dilate.
Yeah,
right?
don't need. Yeah, I think it's actually 0 position.
Right. So device is stabilized.
Stable, yeah.
Cool.
And
Everything
there
is
is
fine.
no RBVV.
So finally, can you summarize in 2 or 3 sentences about the case?
Okay. So today's case is a typical severe aortic stenosis with a high risk for surgical procedure. So we perform TAVI for this case. And considering the baseline ECG is right bound block. So for this case, I think we decided to use a high position deployment, avoiding pacemaker implantation rate. So during the procedure, also this case is CKD with a 3-stage. So during the procedure, we use TE guidance to reduce the contrast consumed to decrease the risk of a CI. So final result showed excellent result. So good valve deployment at the 0 position, just at the aneurysm level, and with a mild regurgitation. And the ECG, there is no change, which means no need a pacemaker implantation. So that's all. Thanks my team, thanks my boss, thanks the online audience and the colleagues.